Thank you for the introduction and also for the invitation. So over the past few years, and also as we've witnessed this morning, we've seen a paradox. We have thousands of patients with long COVID with severe symptoms and severe disability, yet very little consistent evidence of ongoing injury or disease in the body. So today I want to ask a different question. What if long COVID is not a chronic multisystem disease process? What if it is a reversible disorder of brain-body signaling? Let me tell you about Mary. So this is actually a real person, anonymized. Mary got COVID in 2022, and she, after her infection passed, she never really recovered. Her symptoms even got worse. And her main symptom was a burning sensation in the throat that never went away. She developed brain fog, fatigue. She was not able to work and was partly bedridden. And after a while, she started to think that this would be her life from now on. And then one day, accidentally, she ran into one of the investigators of this trial that we were planning. So we had developed this new treatment that we'd call the mind-body reprogramming therapy, and we wanted to test that out in a large randomized controlled trial. But before that, we wanted to do a small pilot study, just testing it out and get some feedback. And this investigator, Maria, she said, "Hey, do you want to try this new treatment that we developed?" And Mary said, "Yes." And she was actually one of the very first patients to try the MBRT, the mind-body reprogramming therapy. And today, Mary is back at work, living her ordinary life, walking her dog, and she's fully recovered. And so to understand why someone like Mary can recover, we first need to take a step back and ask a more fundamental question. What are symptoms? So in medicine, we are trained to think of symptoms as signals coming from the body. Something is damaged, inflamed, infected, injured, and the body sends a signal to the brain, and the brain experiences that and then send out these symptoms. And sometimes that is true. But modern neuroscience has taught us that this is only part of the story. The brain is not a passive receiver of information. The brain is an active prediction machine, constantly trying to guess and make sense of what's happening in the body. So symptoms are not just inputs from the body. They are, in fact, outputs of the brain. And to understand that, it often helps to look at how the brain works in other systems, like vision and hearing. We tend to think that we see the world as it is, that there's an objective reality out there, and that our senses, our eyes and our ears are just windows into that objective reality. But that's not how it is. And we've known that for quite a few years now. You don't see the world as it is. You see the world as your brain predicts it. The brain is combining two sources of information. The expectation based on previous learning and contextual cues and all this kind of information. And the other is sensory inputs coming from the outside world. And this is an important point. Sometimes that information is compatible with various interpretations. And if that is the case, if there's actually various interpretations possible, the brain will rely more heavily on expectations, on the predictions. So that's why optical illusions work, because what they do in optical illusions is to introduce a little bit of ambiguity, which makes the sensory input compatible with multiple interpretations. And then what we see is heavily relied on our expectations. So in this famous hollow mask illusion, you see this rotating mask. And since we here have introduced a little bit of ambiguity in the lighting, the brain is starting to get confused and actually never see. I guess most of you see a normal face all the time here, even if the mask is rotating. And so since all of us have seen hundreds, maybe thousands of faces in our lives, the brain is a very strong prediction of that. But I hope none of you have seen the backside of a face before. And so the brain does not have a prediction for that. And so when the sensory input is a little bit ambiguous, the brain makes up its mind and says, okay, probably the face is pointing outwards. I have a strong prediction of that. That's what I know from before. So the brain is not trying to be correct. The brain is trying to be efficient and predictable. It sees what it expects to see. And since we are in Paris now, I thought it was really fitting. So, and it's the spring. So most of you will read this sentence as Paris in the spring. But if you look more closely, you will see that the word the is mentioned twice. Your brain didn't read the sentence. Your brain predicted the sentence. And this is how perception works. And the same goes for hearing. So you don't hear the world as it is. You hear the world as your brain predicted. So you're about to hear the exact same phrase now, a song phrase repeated over again. Nothing changes in the audio, only the words on the screen, yet most of you will hear it differently. You don't hear the world as it is. You hear the world as your brain predicts it. And the exact same thing seems to be the case also for our experience of the body, what we call interoception. And this is where the new modern neuroscience has really taught us something new, that this is not only how the brain works in perception, but also in interoception. You don't feel the body as it is, you feel the body as your brain predicts it. And one of my favorite way of sort of demonstrating and explaining this is by going through the rubber arm illusion. So in this illusion, it's a famous experiment, done tons of research on it. You have a person sitting as this and hiding one arm behind the screen and then putting a rubber arm in front in the same sort of angle. And after a while, when you sort of stimulate both the rubber arm and the hidden arm at the same time, the brain starts to associate the rubber arm and adopt it as its own. And this is actually me doing the rubber arm experiment on 3 random students on national TV last year. And what's fascinating is to see how quickly the brain adopts. And remember, there are no signals coming from the rubber arm to the brain, obviously. Yet the brain starts to believe that this arm probably is mine. Every evidence is pointing in that direction. It seems that way. And I'm just going to assume that this is the case. And this has been done, experiments on, as I said, and shown to be able to work. And the funny thing is, after a while, that when the brain really starts adopting this, you can do all these crazy stuff with the hidden arm, pointing or pinning a needle through and injuring it a little bit without the person feeling it. Whilst if you start to threaten the rubber arm, most people will react with discomfort, and some will even react by experiencing real pain. So the brain does not simply detect the body. The brain is constructing the body with available evidence. So if symptoms are perceptions generated by the brain, that should plausibly imply that if you change the expectations, the predictions, we should also be able to change what we feel. And that's exactly what we've seen and what we have seen in the decades of placebo and nocebo research that we have. And this has been a phenomenon that's been known for quite some time. So just to make that clear, when patients believe that they're receiving a painkiller, the pain often decreases, even if the pill contains no active drug. So this is what we call placebo analgesia. And so for a long time, it's been known for decades. But for a long time, we thought that this was due to imagination or reporting bias or exaggeration. We didn't really have the proper concepts of understanding and explaining what is really going on here. We saw these effects, but we didn't understand them. now we have a more proper understanding. And I think this is one of the earliest studies who starts to show what the mechanisms are and how deeply grounded this is in biology. So this is a study from Bernadette and colleagues, and they get healthy volunteers into the lab and inflict pain on them, ischemic pain, which is really, really painful. And you can see that the people here are on 7 on the pain scale from 0 to 10. And they are at the same time having this IV infusion, this intravenous infusion through a tube in the arm. And they can see some fluid coming in there. It's really just saline salt water, but they are told that this is a really strong painkiller that will really decrease the pain that you're now feeling. And of course, that is happening. Pain relief as a result of placebo, which we've seen multiple times. But then after about 25 minutes, something happens. The investigators are injecting naloxone into the tube, into the IV, without the people knowing it. And naloxone, for those of you who are medics here, know that that is an opioid antagonist. So it binds to the opioid receptors in the brain and basically nulls out, blocks every effect of opioids that you can have. And what happens in that group is that the pain goes back to the starting point. Whilst for those who do not receive the naloxone, who just continues to get the placebo, the salt water, the pain relief is still there. So what does that mean? Well, it means that placebo analgesia can be blocked pharmacologically. So this means that placebo is not fake treatment or fake effect. Placebo is biology driven by expectations. Okay, so if this works that well on the positive side, there should also be a downside to this. And that is exactly the case. We have now a lot of research also showing the effect of negative expectations. And in this study, it's very strongly demonstrated by Bingham and colleagues. First were participants, healthy participants again, they were given pain, really heat pain in this study, until they reached the scale of, as you can see here, more than 60, between 60 and 70 on a scale from 0 to 100. And then they were also having this intravenous tube and were receiving a potent opioid, remifentanil. And I don't know how it's here in France, but in Norway, if you're going to do surgery and go in for general anesthesia, remifentanil is part of the cocktail that you get to sort of knock you out before surgery. So they were given this in a dose that would be sort of fairly potent, but they didn't know that they were receiving it. So that's the first bar here that you can see, the effect of the medication without knowing it. So a little bit pain relief, not that much. Then the investigators say, well, now what you see coming into the tube now is real pain relief, is a pain medication, strong pain medication. And here you can see how the effect is increased even more. So here you have the effect of the medication plus the placebo, interestingly enough. But then the researchers are saying, now we're stopping the medication. So what you see coming into the tube now is just really salt water. It's nothing efficient. Whilst in reality, they continued to give the pain medication. And what happens? The pain goes back to the starting point. So what does this really mean? It means that the negative expectations, believing that they were no longer receiving the drug, blocked the effect of a potent opioid. So in order to help you understand this even more, we have we use metaphors. So, and we've made this demonstration to sort of pin down and really help you to understand sort of the mechanisms grounded in this model. So if you use pain as an example, pain is not just a signal from the body. Pain is a result of how the brain combines two sources of information, signals from the body and the brain's expectation of danger. So here you can think of the brain as a mixing desk, constantly trying to adjust the volume of each of these sources of information. And sometimes the pain is mainly driven by signals from the body, such as if you put your hand on a stove and burn really badly, there's a really strong and really precise signal coming to the brain from activity in the nociceptors, sending it up to the brain. The brain decides very quickly, this is a very credible signal. Probably it's smart to put on the alarm here. So it turns up the weighting, the volume of this source, and then the pain is turned on, the pain alarm is turned on. But sometimes the opposite happens. We have this very famous case story published in the British Medical Journal of this construction worker who's at the construction site, and he jumps down from a height and then right onto a nail that penetrates his shoe, as you can see here. This is from the actual paper. And he screams in pain. He's really, really strong pain. And his colleagues are, panicking, calling for an ambulance. The ambulance comes and he is put into the ambulance and rushed to the hospital, given pretty good doses of fentanyl and midazolam, and he responds pretty good to that. And after a while, they remove the shoe and they see a miracle. The nail has not gone through his foot, but between his toes, like this. So there is no injury, no tissue damage, no blood, nothing. Still really, really strong pain. How is that possible? In this case, the brain has weighted the brain's expectation of danger really, really high, and just there is so much indicating that there is a threat here. You can see the nail going through the foot. The colleagues are panicking. He's in a context that is dangerous, so probably he's a hypervigilant from the beginning. And maybe he even has experience from before. I'm guessing that since he reacts so strongly. Maybe he has experienced the same before. He has that stored and into the sort of the prior predictions. But yet there is no injury at all. Sometimes this system becomes overprotective, as we also heard this morning. The brain can start to give more weight to learn predictions of danger than to the actual signals coming from the body, signaling, everything is okay here. So if you have, for instance, had an injury in your hand, maybe broken an arm or something, and the injury heals, the prediction can stay on, and the brain can misinterpret the signals coming from the body, thinking that probably it's safest to just turn up the volume here, and then turn on the pain alarm. So, and the prediction can be activated again and again, especially in similar movement situations or contexts. And the symptoms continue not because of ongoing damage, but because the brain continues to predict danger. So in treatments, what we're trying to do, the whole project of all various treatment models, is to try to update the brain's predictions to help the brain understand that the body is safe again, and that this volume of these expectations can be sort of turned down. And that is what we try to do in the mind-body reprogramming therapy. In the MBRT, we aim to help the brain update its predictions so that the alarm turns down and symptoms can reduce or even resolve through new learning. So what is MBRT? It's an intensive format. It goes over a period of 7 to 10 days. It's interdisciplinary, involving physicians and psychologists or psychiatrists, and it has a hybrid format, and it was specifically developed to target long COVID patients with really severe disability. And it has 3 parts. The first part is to provide a new explanation after the patient has gone through all the assessments and procedures, and then provide a new explanation. And then we go on to the actual treatment, where we do different techniques and exercises to help the brain update its predictions through new learning. And then we have the digital modules to help the patient to continue this work on his or her own. So the treatment is based on 3 theoretical pillars. The first is predictive processing, that I've shown you some insights in today. The other is classical and operant conditioning, that I will show you some examples of later, or learning theory. And the last one is relational frame theory. And since it can become really abstract and theoretical, I'm going to show you a very concrete example of the latest here, the RFT, relational frame theory. So I want you to think of a lemon. So try to imagine fresh, juicy lemon. Imagine to cutting it open, seeing the juice, and then taking a big bite of this lemon. If you do this and try to associate all the attributes you can think of when it comes to a very fresh lemon, many people will notice that something is happening in the body. maybe salivation, maybe a slight physical reaction. Nothing really happened to your body, but your brain predicted something, and the body responded. And now I want you to do another thing, to just say the word lemon over and over again for 10 or 15 seconds. So lemon, 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 lemon. You can actually do that. It's okay. Lemon, 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 lemon. We do this in treatment, and when we do the treatment, we do it for 45 seconds, because that's what research shows that it takes to sort of break that response. So then it becomes just a word, and with no more bodily activation. So it loses its meaning by repeating it for several seconds. And we use this both to show how powerful the brain is. Just by thinking of something or saying a word, you can actually activate a bodily response, but also to show how we can sort of, this is called a diffusion exercise, how we can sort of separate those words from its meaning by repeating it over and over again. And we use that in treatment, particularly for thoughts and words that holds negative self-referential meaning, such as I'm weak, I'm damaged, I'm worthless, and all these things that we say, and we all, but also patients say to themselves, and words that bear a lot of negative self-referential meaning. We use this exercise to sort of diffuse and give the brain new learning. So we start the session. We start with the first session with a physician, which is a medical assessment, review the findings, offer reassurance that there is no underlying medical pathology, which is a very important premise here. And then we have put that aside. The patient is left with, well, what is it? Why do I have all these symptoms and disability? And we provide a credible explanation for that persisting symptoms. And I'm going to give you a brief insight into that explanation. So remember the mixing desk? Where the brain adjusts how much weight it gives to signals from the body and how much weight it gives to expectations. We can, of course, expand that to other symptoms as well beyond pain, because all symptoms are fundamentally constructions by the brain, alarm systems that works under the same principle. But then we have to ask the question, where do these expectations come from? Why does the brain sometimes expect injury, illness, danger, even when the body is fine? And the answer is learning. The brain learns from experience. And once the brain has learned a pathway, it can start producing symptoms automatically, even without ongoing injury or disease. So, metaphorically, we explain this to the patient by showing these graphs, as I will show you now. We can imagine that the brain, when we are born, the brain is like a vast field. No trails, perfectly. And then as we start to learn things and experience things in the world, there are small trails being paths in this field. And as we repeatedly walk certain routes, we create trails that make it easier to pass. And the brain has two main strategies to build stronger pathways, and actually also highways and that are connected to each other. And the one strategy, the first strategy, is to walk the trails many times. So it's repetition. And the other one is what we call the bulldozer effect. It's when we experience something through intense experience of threat or danger. So think about touching a hot stove when you're a kid. You don't need many repetitions of that. You know, the brain is instantly creating a highway. Stove means danger, not doing that again. And this is important because these pathways don't just reflect what happens in the body. They reflect how the brain learns to interpret what is happening. So the disease may be over, the infection is cured, the injury is healed, but the pathways remain through learning. And we can have various individual examples of how these pathways are made and how they've become so strong, because I believe that patients with long COVID will have a highway, a neural highway in the brain signaling sickness. And every little road is leading into this highway and is very easily activated. And there can be many pathways into that. Maybe for one individual, he had a very severe acute infection, got admitted to the hospital, extreme symptoms. That's like the bulldozer effect. The brain learns really, really rapidly that here is something that is to associate the disease state and all that's, reminds of that with danger. Another patient might have just have a more mild infection, but maybe it was a time of high stress at work, at home, a lot of anxiety, a lot of uncertainty. And then we have the brain and the whole system on high alert. And when we are on high alert, we know that the brain more easily detect danger and start associating, start learning, almost also like the bulldozer effect. Or we can have a more subtle ways into this sort of highway that are not so obvious. But this new model opens up for all these various trajectories into the sickness highway that becomes really, really strong and repeated so many times that the symptoms are very, very easily activated. This is another very important point of the treatment. It is not your fault. The brain learns this automatically. And I think this is where we get it all wrong sometimes, because when we explain these models, what some patients hear is then it's only in my head and it's something I can easily control. No, it's not. It's not something that we have very direct access to through our conscious mind. And we use learning theory because everything here is grounded in learning. We use that as an example. And so think of a time when you got food poisoned. Any of you experienced that sometimes? No, lucky you. I got food poisoned once. I was working on the other side of the world in a humanitarian organization, and they had this very little money, so they had this meat delivered for free by a store that was expired on the date, so it was way beyond expiry dates. And 99% of the times that was fine, but that 1% of the time it was not fine. And me and some other us, we ate this meat. It was not good. And we got really, really sick. It was meatloaf. And this is now more than 20 years ago, and I can still not eat meatloaf. Just the thought of a meatloaf makes me nauseous. And if I were tonight to be presented with a delicious meatloaf in a really fancy French restaurant, it could be as good as ever. I would not be able to eat it because my body instinctively reacts. And I can know with my rational mind that, this meatloaf is probably the best in the world. But still, my body reacts. It's an automatic response. So knowing it is safe does not switch off the alarm. It's a first step. It's good for me to know that this meatloaf is safe, and then I have to sort of work from there. But it happens automatically. I use another example with a patient of mine who starts throwing up when she sees the hospital. And that's because she's been through really, really rough chemotherapy that made her really sick. And so the brain starts associating the hospital with that reaction, with danger. And so just the sight of the hospital makes her throw up. That's not something that she's doing purposely or can easily access to sort of switch off. And that helps us and patients to understand that this is not something that we do on purpose or voluntarily. But still, it's something that we can indirectly access and do something about. New learning and repeated safe experiences can change prediction. Small bites of the delicious French meatloaf could maybe have me eat that again, perhaps. So then we go on to do the core techniques to try to help. And we have to do this more sort of in indirect ways because this is automatically, 90% automatically in the unconscious brain. So we do various exercises. We use symptom exposure and behavioral experiments to help patients experience that the symptoms are not dangerous. We gradually increase activity and function so the brain learns that movement and activity are safe. And we do also emotional regulation and stress regulation. And here are elements from other treatment modalities, such as the pain reprocessing therapy. We do interoceptive exposure. We do gradual behavioral exposure. And I wanted to show you one example, again, just to make it more concrete, because it can be a bit abstract. So one example here is the interoceptive exposure exercise that we do, where we have the patient and mention a trigger situation. So most patients will have a trigger that if they know that if I do this, the symptoms will be like crazy, exacerbate. So for many, that will be running. So then we have the patient imagine the trigger situation and as vividly as possible. And we do this visualization to walk them through all the steps. Imagine that you're out there, you're running, and then have them notice what's going on in the body. Most of the patients will actually have symptoms appear just by doing this visualization. So we use that symptom as an opportunity for new learning. So first of all, that in itself is the personalized evidence that the brain can generate symptoms. We can both agree on that in the therapy room, that just by thinking about something, you activate the symptoms. That has to be the brain. What else would it be? So you sort of get a personalized evidence of the explanatory model that we've gone through. And then we use this as a way to have new learning. So I would have the patient imagine the situation again, do the whole visualization again, but this time introduce a lot of positive elements. So we would say that it's a beautiful day. You are there with a friend. Maybe put the whole situation in your favorite place on the beach. Your body's working. You have the best running shoes ever, and just imagine doing this again. And most people will then are able to do the exercise without having any symptoms, but feeling calm and nice in their bodies. So we do this interoceptive exposure in a context of safety. And that's sort of the first step of taking it out into the real life and actually taking that safety out into in vitro and to do this in vivo. The digital modules are there to support patients to continue. This is a very short and intensive treatment to have them keep going and exercising. So we have a lot of audio files and resources. And we have not published the results yet, so I can't share any specific numbers. But it's very encouraging to see how the results are so far. The majority of the patients that are in this trial, this is a large trial of 310 patients that are randomized. They show clinically significant improvement. And one thing that I just wanted to sort of specifically mention, because there's a lot of talk about post-exertional malaise, PEM, and we did measure that in this trial. And I just looked at the graph before I sat on a plane to get here to Paris. And what we see there is at the beginning, at the baseline, most of the patients score really, really high on PEM. After the treatment, it drops like a stone and it stays down. It's gone for the remaining 1 year follow-up. I think we need a new way of thinking about long COVID. I think we need another model. The biomedical model has failed and is still failing, and it's a mistake of medicine to introduce that as the explanation for this for these conditions. We need a model that can explain why patients are so disabled, why so little is found in their bodies, and why some people can recover, sometimes dramatically. And I think this model is able to do exactly that. So my take-home message is the symptoms are real, the disability is real, but the brain-body processes generating them may be reversible. If the brain can learn to create these symptoms, it can also learn to stop. Thank you.
Thank you. Yep, thank you. Very nice presentation. Of those patients that do not recover with this treatment, have you followed them up to understand what could be the reason why they don't recover?
We are still analyzing that now, but we know from previous studies from the same group that biomarker findings are not able to predict non-recovery at all. And we have not found any demographic variables to explain it so far. But I think that's an important lead. I think it's also important to do both, right? To look at those who do recover, what characterizes them, and to those who not recover, what characterizes them, and how can we sort of shape. I think for some, the anecdotal reports we've got, for some, they need more This is a very brief treatment. Other treatment models are also very brief. So for some, it takes longer time, it takes more practice, it takes more support to be able to actually update the brain's predictions, which is, in some, it happens instantly. It's amazing to see those dramatic stories. But for some, for various good reasons, it takes longer. So I think some actually need more longer support and longer follow-up.